Good morning, everybody, and thank you for coming. I know how it's hard to come to a basic science presentation, but I'm just gonna try to make it the way that all of us we can understand it. But more important, I want to really showcase what we do at the Prostate Center, and maybe can attract the attention of staff from you to be interested to go and try to discover what we do and can be more interest for you. Here, the objective of the talk today will try to describe the emergence of more aggressive phenotype of prostate cancer around the era that we have castrated resistant and the emergence of this novel drug that they are recently approved by FDA, and what we can do as a scientist to understand the molecular mechanism that we can be a step ahead when those resistance really showed, and we can design drugs for that. I believe that the Prostate Center has been championed on that in castrated resistant, and Martin has 2 drugs that are in clinical trial. It's just a way to tell us and to say what we can do in the lab, and we can translate it in the bench side. We will also try to introduce the concept of combination therapy, and what we try to do with combination therapy until now, we are doing mostly some monotherapy for prostate cancer. Maybe we can mix 2 anti-androgen, but how can we combine 2 different targeted therapy with hormone therapy or with other that can we induce conditional lethality for this prostate cancer? We will also go and discuss some examples that we are trying to develop that we can guide some future clinical evaluation in the future. Well, I'm going to tell you, I know how hard it is when you are a basic science to come to clinician and give a talk. And I'm going to tell you something happened on a Sunday when Andrew asked me to go for a hike with him, which was not a hike, it was a run. I was suffering, and I just started thinking what I can do to complete this hike run and make it enjoyable. The only way to start thinking about how I can come today and tell you about something that can be different. And I thought about this idea, maybe I can start with this scenario. It is, okay, a case. That's the way, guys, that you start your presentation. You have a case here. This case, it is a scenario, but it's inspired from a real case, a patient at VG8. He's a 69 years old. Oh, guys, pay attention with me because I'm going to ask you questions and you're not allowed to look to your emails. Well, you have this patient, 69 years old, and what is interesting about this man, in my point of view, he's rich and he's ready to donate money to the prostate center. His PSA is 23.5 at stage T3A and Gleason score 3+4 and has a negative node. In August 2006, he had radical prostatectomy. October, his PSA is nadir. September 08, starting having a little bit of rising PSA, 0.98, and bone scan was normal. He got treatment. The treatment was Lupron plus Casodex for 6 months, and also had salvage local radiation therapy, which was completed in 2008. July 09, starting having his PSA was nadir. What happened? In June 2013, his PSA is 1.3, testosterone less than 0.1, and a few months later, he starts having a rise in PSA, testosterone still low. In November, his PSA was high. And you can see clearly here, if we're talking about doubling PSA, you can see it is high. And we start asking the question if that is a systemic. Now, this is for this patient. He had a bone scan, and his bone scan showed progression in METs in L4 and new METs in left hip and pivot. What is here? Here I'm having a question for you. Normally is the audience asks question, but I am asking you a question. What are the 2014 treatment option for this patient? I may ask some R5 that you're going to have your exam to answer to this question. What do you think, Mike? Well, I told you to not think about your email.
I have an email. So he's demonstrating rise in his PSA and testosterone. I missed whether or not he can start on any agents already.
What?
Has he been starting?
He's castrated resistant.
So I think with you guys, I should say docetaxel and prednisone be something for castrate-resistant prostate cancer, as well as Abiraterone. And some of mine recently, I think, is had good data to suggest that
What do you want? That's the question. What do you suggest?
Well, you can also try combined androgen blockade for that. But I think probably one of the more novel agents like Abiraterone is still fine.
You are my friend because I like hormone therapy. Here different type of therapy that could be possible in general. Some of them they are in clinical development, like targeted therapy, and you can see here as tyrosine kinase inhibitor or kinase inhibitor. You have also the bone targeted therapy with the ROCK ligand that was approved, and immunotherapy, and you have the hormone therapy when we have enzalutamide and we have abiraterone. There is also some clinical developments of epigenetic therapy and cytotoxic like taxanes. But what we have approved and what we have in Canada, here in red, those ones that they are approved, you have taxane hormone therapy, we are two of them. Immunotherapy, I don't believe that we have that in Canada now, and the bone targeted therapy. You suggested that we can go with some hormone therapy as enzalutamide or abiraterone. And I'm just going to give you a little quick example how it's working. We know that you have rising PSA suggesting that your androgen receptor is active, definitely. And we know that for the activity of androgen receptor, you need testosterone, and when testosterone gonna bind, we have convert to DHT, bind to the androgen receptor, and can get activated, translocate to the nucleus, get activated, and activate all the survival. I believe that you had a really explicit and presentation by pouring about the androgen receptor is not that the goal of today. And there is two drugs, ABI and ENZ. For ABI is block the synthesis of androgen from Clusterin, and here you have targeted the CYP17. However, this patient has low testosterone. And this is another question that we can ask, how we can really choose the therapy for each patient. Well, ENZ, and what is interesting about enzalutamide is a ligand binding domain of androgen receptor. Will bind to androgen receptor. What is interesting, can degrade the androgen receptor and can block his nuclear translocation. But if we look to the data from clinical trial and the survival curves, you can see here docetaxel was approved in 2004 and improved survival 2.5 months, ABI is 4 months, and ENZ 4.8 months. The question here, are you going to give this patient ABI or ENZ? That's the big question. That we don't know until now. We have some low testosterone. Is this one going to be responsive to ABI or not? You are in your practice and you have that, and that is the question that we can ask, because we have two potent anti-androgen that are available. Which one we're going to use? And I think that's the big challenge to ask ourselves, which one going to be first, which one going to be the second, and I don't know. I know personally, I don't really know. I'm not a physician, I'm not an oncologist, I'm a basic scientist, so try to understand some mechanism. Taking the idea that when you look to the data from ABI, there is some patient, a proportion of patients that they don't respond to ABI, and you can see them here. Has been published in 2012 from a group from MD Anderson, showing that there is some subset of patients that are originally resistant to this ABI. It is a scenario that our patient could be resistant to ABI. And why could be resistant? Maybe for instance, we find in the lab, there is some cells that we use in the lab that they don't respond to ABI because they have a low level of CYP17. And maybe there is some patient that they have low level of CYP17, or maybe they have other mechanisms that activate or that block, that they cannot really, maybe the emergence of those splice variant, that they don't have the importance of this ligand binding domain. And the question here, you are facing which one we're going to give to which patient. When that's what I come, and it's just going to start for what I do, and that the drug that I work in the lab, I have a lot of interest in ENZ and the resistance to enzalutamide. Here is just a cohort, for example, from this cohort from France, showing that you have patients, and when you treat them, they go to nadir, however they progress. Now we are saying that as in castration, then you give patient, they become castrated resistance. We are seeing now that patient also become resistant to the second hormone therapy. What do we do now? We have a drug just been approved in 2012. and we already seen the resistance. What we can do to be ahead and try to find a way that we can already predict this resistance, or can we use those drugs in combination with the other to induce conditional lethality for the tumor, and we can improve patient survival? We have good drugs, but are they sufficient? Are we doing harm or doing good to the patient at the long term? What would we try to do to understand, for instance, this mechanism of this resistance here we want, and we try to model what's going on in the clinic, the castrated resistance, the second line of hormone, first line, second line of hormone therapy in the lab to help, because this type of model was successful to identify Clusterin and HSP27 that they are now in clinical trial in the lab. We went and we modeled that in those tumor in mice, and we can clearly see that we can have an effect of the drug, and we can block, we can inhibit the PSA, block tumor growth, but with the time we can see, as in patient, we increase the tumor growth and we can see the resistance. The recurrence appear, and this recurrence is really related to this activation of the androgen receptor. When looking, you are surgeon, you're not an oncologist, but I believe oncologists, they look at all the time, patient by patient, to identify if somebody really responds or other they don't respond. We try to do the same thing in this cohort of animals, and we see that we have proportion that they are sensitive to the drug and they respond pretty well to the drug. However, they show type of the resistance as shown here with the red line. The question, what is the difference with this one? What makes some patient respond to the drug and other they resist? This one, in general, this one, they are sensitive and they respond to the drug. We forgot about them, but we are interested to this one that they resist because we want to improve their life. Look into this one that they resist, and it is something that is not only seen in our experimental model, but also in the patient in the clinic. You can start having, you're going to have like a patient come in with increasing of PSA, and you will have another one with his PSA is around 0, but having metastasis everywhere. It means that his disease progressed, but he didn't show any chemical recurrence related to the PSA. I know that you don't have, you don't see a lot of neuroendocrine prostate cancer, but this one that you can have this recurrence for those patients without the chemical recurrence, they can be type of neuroendocrine prostate cancer, for instance. And more people start seeing that with this maximum androgen blockade with very powerful drug that you can lead to the emergence of this new type of cancer that we should really be aware about. Now we have models in the lab that we can probably mimic what's going on in the clinic to better understand and to see what we can do. And our goal in the lab is to understand this mechanism and design some combination therapy to guide clinical trials. When we went and we start looking, the first thing that you start looking, and the winner, because you have to be somehow opportunist, you go to this graph in the bottom when you can have a recurrence with PSA, something that you can model, because we understand very well castrated resistant process, not very well, but somehow castrated resistant. Well, we're gonna go and see, do we have the same scenario in this one with PSA recurrence? Well, we found that, for instance, in castrated resistant androgen receptor is upregulated. We see the same thing. Here are we having a very powerful or aggressive another castrated resistant here that we're going to hand up with that's going to be more aggressive, or another beast. Well, here androgen, we found that when you have androgen receptor active, it's been measured by PSA, those tumors, they progress and they proliferate very well. It's mean that those tumors, they're going to be more aggressive as compared to those ones that they are sensitive. More importantly, androgen receptor is found in nucleus. It's mean that it is active. And again, telling us we are facing another type of cancer. It's just not type of cancer, another more powerful one, which is again dependent on androgen receptor. But the idea, if it is dependent on androgen receptor, first of all, you have castration, they become castrated resistant. You give them a second line of hormone therapy, are more potent somehow, Casodex, which is MDV or ENZ. Can we give another more potent one and see if we're going to make it better? Can we just go to this serial of anti-androgen, or we have to rethink about our way to manage that? What I can tell you here, there is here a component, for example, 30, which is also an anti-androgen. We can look, if you look here, that when we treated induced resistance, we can inhibit, for example, we can wipe up the PSA. How about in real tumor growth? You can see after the treatment, we can affect the PSA, we can affect the tumor growth, everything. Okay, maybe now we found another third line of hormone therapy that's going to help us in the future to maybe counter that. However, what we see, our tumor become more aggressive, and you can really appreciate the doubling time, how this PSA level is going up to the roof. And what we can conclude from this study, maybe the idea of targeting the ligand binding of androgen receptor has to be forgotten. We don't believe, because maybe we are just inducing at this moment a very aggressive cancer that we have to rethink again about other ways to do we have to be more imaginative in not just targeting this androgen receptor. With that, we get to the point that we really need other way or alternative therapy to attack this ENZ resistance. What we did, we are basic scientists. What we do gene profiling, we do sequencing, we look at the pathway analysis. That's what I do every day. And we were very surprised to find the same pathway that they were upregulated in castrated-resistant prostate cancer. They are also upregulated but amplified with this the second generation of anti-androgen. We can find of them, like you have the pathway of the novel synthesis of androgen is also upregulated. You have molecular chaperone, they play a role in the stability of androgen receptor, including clustering, that they are upregulated, and all the signaling pathway, including the tyrosine kinase and also the AKT survival pathway. This moment we start to say we have a good drug, which is ENZ. If we try to look and try to really use the other targeted therapy, because here we're going to be with another targeted therapy in this situation, what we can do. I'm going to give you a few examples of that, and we're going to move on from. We went and if you remember, there is here the upregulation of the CYP17 pathway or the novel synthesis. The first thing you're going to think, Mike said that we can have Abiraterone. You can think about, if we add Abiraterone in induced ENZ resistance, what's going to happen? Normally, if you have this upregulation of this pathway, you will think, well, here is a clinical trial. We submit a grant for that, and we got some money for. But however, just after that, there is this clinical trial came out and showing that Abiraterone has a very modest, it is the way to wear in that, very modest anti-tumor activity in patients with castrated-resistant prostate cancer pre-treated with ENZ. It's mean this sequential therapy has only modest anti-cancer activity. And the question here, maybe we're ending up with adding those two different anti-androgen with the same mechanism of resistance, and we have again to rethink and to find a room or to find a new therapy for us. As I said, if I go back, I show this receptor tyrosine kinase and this pathway activated. We said, okay, if we take this tyrosine kinase receptor, TK, and we had an inhibitor for that, if that's gonna work. I'm just gonna tell you a brief example. This pathway is important for survival, but also can activate the androgen receptor. If we use that, could be good for this resistance. Well, first of all, we show clearly here that this pathway is activated in our cells, and I don't really need to go in detail. And induced tumors, you have upregulation of this receptor tyrosine kinase. Well, if you look to the literature, there is some clinical trials showing that using an inhibitor of this tyrosine kinase has very modest activity or no activity in castrated-resistant prostate cancer. And when I was reading the paper, it was a statement by Johan de Bono saying administering Lapatinib, which is an inhibitor of tyrosine kinase, together with anti-androgen may be useful. It's mean using the drug alone in a very aggressive tumor is not going to be good, even there is all those clinical trials. That gets us to the idea about combining therapy, because we have this protein that they can get upregulated, and at this moment you start thinking maybe using this targeted therapy in a very aggressive setting will not be good. How about combine it and use it from the get-go, because you have a very good drug and you want to enhance the activity of your drug, and you want a really, because sometimes the deal or the challenge, instead to talking about now curing, can we at least delay the time of the progression, of the time of the recurrence? I'm just gonna go. That is not important. Is some in vitro studies showing that those drugs can be synergistic, and also in our model we can see that has an effect on PSA. Here you can see here treated with ENZ alone or in combination in PSA, but also in tumor growth. If you see this slide showing, yes, we can achieve, but we cannot achieve a really conditional lethality for the tumor. We still have room to improve. As you can see here, the difference between this red line and here, that we have room to improve. Can we find another type of drug that can improve that, and we can induce more conditional lethality? And for that, we went to another drug that now is in phase 3 clinical trial with taxane, and we said Clusterin, where we don't look for a protein or a stress-induced protein that is involved in different signaling pathway, and this can affect cell survival. And if we target it, and there is a precedent in the clinic, for example in phase 2 clinical trial, it's been effective as a combination therapy, can that work in this setting? Well, here just some data to show that in the resistance, this protein is upregulated, clusterin is upregulated. And what is more interesting, clusterin is upregulated not at the late stage, not at the end of the resistance, but can be induced early. And that induction early with the treatment is a way, or it is an indication that you can combine it earlier, that you can inhibit. If you inhibit this protein at the get-go, because this induction of the protein is a sign that your cells, they're going to survive and they're going to resist. And that's what we did. We combined them, but what we were very surprised to see, when we combined these two drugs, we didn't only affect the survival of the cells, but also we were able to degrade the androgen receptor. Here we have some treatment in combination that can affect different signaling pathways, not only the survival, but also the androgen receptor. And here the data from the tumor growth, and you can see that we're really affecting the tumor growth better than the other targeted therapy, and we're affecting PSA. Again, I still believe there is room of improvement, and there is other drugs that we can also start to think about combining them and see. And one of the major players, not only in prostate cancer, but also in other cancer, is the AKT pathway, and the P10, loss of P10 is very important, happening in 70% of prostate cancer patients. We went and we tried to see if this pathway is also activated. It has been reported before that the AKT pathway is upregulated in ENZ, and we went and we analyzed that. And we found that this activation of this survival pathway also occurred early. Now what we're trying to do, we're giving you some example. You can see that there is different molecule that can be targeted, but which one we're gonna really look for. Don't forget that we are really in the future going to the precision medicine, and patients are different, and this difference between patients is giving us the luxury to start trying different things, but also it is very frightening, because what I'm going to give to which patient. When we see here that AKT is upregulated with the drug, And when we combine it, we can induce really a decrease of cell proliferation. We can induce apoptosis when they are combined, and you can really appreciate the difference between here and here, or this one. And they are synergistic. But how about our animal model? Well, it's the first time that we see that. We see clearly here that we, in this situation, we affect strongly the effect, the PSA, and we almost wiped it out. And after even 12 weeks of the treatment of this combination therapy, we were affecting the PSA, and we couldn't detect any PSA at this moment. We were capable to achieve some conditional lethality in this situation because of the tumor that you are working with them in this situation. They are dependent of this pathway. Again, is that's the challenge. Sometimes you're doing some clinical trial and you don't have all the patients that they are dependent on which pathway. I believe that in this situation of those tumors they are really dependent on this pathway, and when they are combined with AKT with an ENZ, we were capable to achieve this conditional lethality. In the objective, and if you remember, I said about this, that I'm going to introduce you to a different type of prostate cancer, and I showed you this type of tumor that they don't have chemical recurrence. This means no PSA. If you remember, like if you can look here, the tumor grow fast and the PSA is so stable here. Well, we want to understand what happened to this type of tumor. We find them that they hang out alone here, not with the other tumors here. They are not like for example, this 49C, that they are more powerful castrated resistance. If you look here, because they are here in the area with castrated resistance. This one, they are alone in this situation. And as you can see here, that they don't produce PSA is a sign that their androgen receptor is not active, and you can appreciate it here. We try to find what we have in this one. What is the phenotype? Are we having a new cancer, or we're having already cancers that they are in the clinic? To our surprise, we find that those type of tumors or cells, they're starting upregulating what we call embryonic pathway. Just think about it. You are somewhere and somebody came and scared you, and you just become like a little kid or something, you know. We believe that's what happened to those tumors. They become more in an embryonic phenotype, in a state that they are in a stress state. But normally, when we think about embryonic, it means that the cells, they can become whatever they want. And that's what's happening here. They become like stem cells, and I'm not going to go to details about how are those stem cells, the characteristic of those ones, because that is not important. But more interestingly, we found that those cells, that they become type of embryonic, and they can become whatever you want them to become. They start, or they present some immune evasive marker. It means they are capable to evade the immune system. Here we're going to end up with some tumors that are going to be sometimes really hard to target because they are evading the immune system. And more interestingly, we find that they can have also some neuroendocrine differentiation phenotype, and that's what's going to let us to understand. And what is interesting, like I said before, more and more we start seeing this type of cancer emerging, and that's maybe what you're going to see in your clinic with this maximum androgen blockade, that you have to be aware when a patient comes with all metastases in the peritoneal, but you know PSA, and you have to maybe rethink about and see maybe they are neuroendocrine prostate cancer. And there is also people in Seattle saying that now they are ending up with some cancer that they are not neuroendocrine. They don't express, and they are more anaplastic, and they are trying now to characterize this novel cancer that appear in those patients with maximum androgen blockade. We are interested in neuroendocrine prostate cancer, and here just an example, just going to give you an example. We identify two genes that they are upregulated in those tumors, which we also found that they are upregulated in neuroendocrine. Now we're trying to see if those genes or those proteins are drivers or only they are markers of this disease. If they are markers for the disease, we hope that we can add another marker to the pipeline, or if they are a driver of the disease, we're going to manipulate them and see what we're going to observe. And here where we are with this study about this more aggressive cancer that we end up with. And what I'm going to tell you in summary, that the resistance in ENZ is very heterogeneous, and you cannot just think that you're going to have the same resistance, and not all the patients they're going to respond to the same treatment, I believe. We believe that targeting androgen receptor using the ligand binding domain is a short-lived. Well, co-targeting androgen receptor, for example, with AKT, with autophagy, by targeting clusterin is a good co-targeting strategy. And we should not forget that with this maximum androgen blockade, using this very powerful drug, lead to the emergence of a new cancer with some cell future that they're going to become who they are, and we don't know what's going to be the fate of this cancer. And at the end, I would just thank everybody in my lab and my collaborator, and also my mentor, Liv, and all the agency, and thank you for staying with me and following that. Thank you.